Happy Nurses Week to all the nurses and future nurses listening. To celebrate, I'm having a 20% off sale on Study Sesh. This is my private podcast that features over 140 episodes to help you study on the go. Formats include pod quizzes, power hour deep dives, drills, and case studies. If you're tired of sitting at your desk or staring at a screen, but still want to review for nursing school, it's time to check out Study Sesh. Go to straightanursingstudent.com and click on Courses in that top menu bar. That's straightanursingstudent.com and click on Courses in the menu bar. See you there. Well, hi there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and at the bedside. I'm so happy you're here with me today. We're going to be taking a bit of a deep dive into hyperkalemia, or an elevated potassium level. Now, before we do that, let's take a quick minute for a listener shout out, and this one goes out to Diane, who says this. I was struggling with nursing school, trying to find resources to help me connect the dots. The videos and resources in Straight A Nursing helped me accomplish this. They are thorough and up to date. The content is presented in a way that clicks for me. My grades have since reflected an increase in knowledge, and I'm feeling more confident in my studies. Straight A Nursing has been a game changer for me. Thank you so much, Diane, and I'm so happy that I have been your study buddy to help turn things around for you in nursing school. That absolutely thrills me. I would love it if you would take a minute to write to me when you graduate, when you get your NCLEX, so that I can celebrate along with you. Alrighty, are we ready to dive into hyperkalemia? So hyperkalemia is an elevated potassium level, and it can have some really serious consequences if it is not treated. So in this episode, we're going to talk about what causes hyperkalemia, the clinical signs and symptoms, how it's treated, and how at-risk patients can help try to avoid it. Now, before we go down that pathway, let's do a little review about the role that potassium plays in the body. So potassium is the most abundant intracellular cation in the body. So intracellular, meaning most of it lives inside the cell. So that higher concentration of potassium inside the cell forms an electrochemical gradient that is maintained by the sodium-potassium ATPase transporter. This gradient is absolutely essential for nerve transmission and muscle contraction, including cardiac muscle contraction. Potassium also plays a key role in intracellular fluid volume and has a close relationship with its buddy sodium, which is the main regulator of extracellular fluid volume. So potassium is an essential nutrient that is acquired through nutrition, but if we don't get enough through nutrition, we can get it through PO or IV supplementation as well. It is primarily excreted in the urine, though small amounts can be excreted in the stool, and a normal potassium level is about 3.5 to 5 millimoles per liter. So why do we care so much about hyperkalemia? Why is this such a big deal? So when potassium levels are dangerously elevated, some pretty serious and scary complications can occur, and these include cardiac arrest, serious cardiac dysrhythmias, if cardiac arrest wasn't serious enough for you, we have some other ones, and significant muscle weakness that can even progress to a flaccid paralysis. And thankfully, though, this paralysis does not affect the diaphragm. Prompt recognition of hyperkalemia is absolutely crucial for improving patient outcomes. I did read a study that said in-hospital mortality for patients with hyperkalemic emergencies is 4.5 times higher than patients with normal potassium levels. So yeah, I don't know about you, but to me, that qualifies it as pretty darn scary. So what would cause hyperkalemia? So some common causes of hyperkalemia are impaired excretion due to kidney disease or the use of medications that inhibit the RAS pathway. However, in some cases, hyperkalemia can be due to other medications such as beta blockers and NSAIDs, and there are a few others. Digoxin is another one. It can also be due to the movement of potassium from the intracellular to the extracellular space, and this is called redistributive hyperkalemia. And this can occur in cases of acidosis or in uncontrolled hyperglycemia. This is something that you would see in a patient with DKA or HHS. And then another cause of hyperkalemia is tissue breakdown, such as in rhabdomyolysis. And if you want to learn more about rhabdomyolysis and all the things that can happen with that complex condition, then you want to go and listen to episode 251 after you finish this one. And the main reason for this is because, remember, potassium is more abundant inside the cell. And as the cells die, like they do in rhabdomyolysis, they spill their contents into the bloodstream, which leads to hyperkalemia. This could also occur with tumor lysis syndrome and crush injuries. And then another cause is gastrointestinal bleeding, and this is because potassium in the blood is being absorbed via the GI tract. So lots of causes of hyperkalemia. Most of the time, though, you're going to see it due to impaired excretion secondary to kidney disease or maybe a medication that the patient is taking. So when potassium is really, really scary high, we call this a hyperkalemic emergency. And a patient having a hyperkalemic emergency is probably going to be having some pretty dangerous signs and symptoms. And this includes cardiac arrhythmias, and these can range from bradycardia to ventricular tachycardia or even ventricular fibrillation and asystole. Okay, that's like the ultimate symptom, right? Asystole. And then they could also have cardiac conduction defects like a bundle branch block, and then muscle weakness or paralysis. And then on the ECG, hyperkalemia's classic sign, and this is always on exams, the classic sign is a tall, peaked T wave. You could also see a shortened QT interval, progressive lengthening of the PR interval, and a widening QRS. And then over time, that QRS just gets wider and wider. And what do you think happens eventually when that QRS really widens out? Basically, we have a flat line or a systole. So we definitely want to get in there and treat hyperkalemia. So let's take a quick break, and when we come back, we'll talk about hyperkalemia treatment.
This episode is brought to you by Shopify. Whether you're selling a little or a lot, Shopify helps you do your thing, however you cha-ching. From the launch your online shop stage, all the way to the we just hit 1 million orders stage. No matter what stage you're in, Shopify's there to help you grow. Sign up for a $1 per month trial period at shopify.com/special offer, all lowercase. That's shopify.com/special offer.
So let's now talk about hyperkalemia treatment. So the treatment of an elevated potassium level is really going to depend on the severity of the condition, the patient's symptoms, how severe they are, and the presence or absence of underlying renal disease. In general, treatment for hyperkalemia follows kind of a three-pronged approach. One is removing excess potassium from the body. Two is driving potassium into the cell. And three is antagonizing the effects of hyperkalemia on cardiac cells. So let's talk about each of these. First is removing excess potassium from the body. So a great way to do this is with hemodialysis. Patients with end-stage renal disease or significant renal dysfunction may get emergent dialysis to remove excess potassium from the body. When I was working in the ICU, this was probably the most common treatment because most of the time our hyperkalemic patients were there with end-stage renal disease. They were on dialysis. Maybe they missed some dialysis appointments because they were sick. Then they got really, really sick, had to come into the hospital, and now their potassium level is really elevated. So they get emergent hemodialysis. Another is diuretics, provided that renal function is adequate, of course. Loop or thiazide diuretics may be used to cause increased renal excretion of potassium. And patients often receive IV fluids along with this so that we prevent hypovolemia and hypotension and maintain renal perfusion. Another option to remove excess potassium from the body is with gastrointestinal cation exchangers. So K-exolate is a really common one. That's the brand name. I usually look up the common names for these drugs. I believe it goes by SPS. It's kind of a long name. K-exolate is what you'll commonly hear it called. And then there are a few other gastrointestinal cation exchangers. What these do is they bind up potassium in the GI tract so it can be excreted in the stool. Because this therapy does not depend on renal function, because we're not trying to excrete it through the urine, it's coming out in the stool, it may be utilized in patients with renal impairment. However, it's not fast. It can take several hours to work, so it is not ever really used as monotherapy in severe hyperkalemia. The patient would be getting multiple different treatment modalities to get their potassium level lower. So let's talk about a different potassium lowering modality, and that is driving potassium into the cell. So one way we do this is with IV insulin and dextrose. So insulin drives potassium into the cells by enhancing that sodium-potassium ATPase pump in that skeletal muscle. And then we add dextrose to prevent hypoglycemia in patients who don't have an elevated blood glucose level. A patient who is receiving IV insulin, and typically it's given as a one-time dose of about 10 units or so. I guess it could be given as a continuous infusion, but generally it's given as a one-time dose. This patient should still have their blood glucose checked hourly for about 6 hours to watch for hypoglycemia. In addition, to help prevent hypoglycemia, the patient may get a dextrose infusion during that time frame. Studies show that in most patients, the serum potassium drops by about 0.5 to 1.2 milliequivalents per liter when administered that 10 units of IV insulin. So that's one modality, very, very commonly used. Another could be a beta-2 adrenergic agonist. So inhaled albuterol can temporarily shift potassium into the cell, but should never be used all on its own. You wouldn't do this and not do the insulin glucose therapy. When used along with the insulin glucose therapy, albuterol and the insulin glucose together can lower the potassium level a bit more by approximately 1.2 to 1.5 milliequivalents per liter. So a bit more effective when used together. And then another one that could drive potassium into the cell is sodium bicarbonate. Since acidosis contributes to hyperkalemia, a more alkaline environment can help drive that potassium back into the cell. Note that this is also not used as monotherapy or the only thing that we do, but instead may be utilized with other treatments. So we've talked about removing excess potassium from the body, and that was through dialysis, diuretics, or something like K-exolate. We've talked about driving potassium into the cell, doing that with insulin and glucose, some albuterol, some sodium bicarbonate. There's another kind of treatment modality we can utilize, and that is to antagonize the effects of hyperkalemia on cardiac cells. And we do this with IV calcium. So note that your patient has hyperkalemia, the MD orders calcium. The calcium is not going to cause potassium excretion. It's not going to drive potassium into the cell. Instead, it's cardioprotective, meaning it helps counteract the effects of hyperkalemia on cardiac tissue. Do note, though, that the effects of calcium, that cardioprotective effect, only lasts about 30 to 60 minutes. So this treatment, again, like the others, is not used in isolation. We still need to do something to either remove the potassium from the body or shift it back into the cell, or ideally a bit of both. This calcium treatment will always be combined with another method. Now, if you're giving IV calcium, note that it is given slowly over several minutes, typically about 1 to 1.5 mils per minute. You'll go by your facility protocol, of course, but as an example, in my facility, if I'm giving 1,000 milligrams of calcium gluconate in 10 mils, it's going to take me about 10 minutes to get that calcium into my patient. So it's administered very slowly. And then in addition to utilizing one of these therapies that we just talked about, it's also important to look at reversible causes of hyperkalemia, such as stopping medications that could be contributing or correcting hypovolemia. So before we close out, let's talk about how hyperkalemia can be prevented. So patients with chronic kidney disease have to really pay attention to preventing elevated potassium levels. So some things that you can teach them or talk to them about or see them doing include dietary modification. The renal diet limits foods high in potassium as well as some other things. And foods high in potassium are things like avocados, bananas, oranges and orange juice, beets, tomatoes, and legumes. You'll notice in the clinical setting, you have the orange juice, it's one of the options. In my facility, it's orange juice, apple juice, or cranberry juice. There might be a little sign next to the fridge that says, "Do not give renal patients orange juice." And it's because of the potassium content. These patients should also avoid periods of fasting. Fasting can cause the body to shift potassium out of the cell, and this is because low blood glucose causes reduced insulin secretion. And with reduced insulin secretion, potassium can shift out of the cell. So non-diabetic patients with end-stage renal disease who are, say, going into the hospital for surgery and have to fast overnight for procedure may receive IV dextrose to avoid this potassium shift. And then these individuals may need to avoid certain medications. This includes things that disrupt that RAS pathway, like ACE inhibitors or angiotensin receptor blockers. Other medications include NSAIDs, some beta blockers, and potassium-sparing diuretics. So there you have it. That is your little bit of a deep dive into hyperkalemia, the dangers associated with it, and how we treat it in the clinical setting. And you might have heard Oliver purring in the background. I'm sorry. He is very attached to me, and he gets really upset when he doesn't know where I am. So he was meowing and meowing and meowing. So I let him come into my studio, and he sat right next to me, right by the microphone, and purred his cute little head off. So if you heard that, I hope it wasn't distracting. Maybe it reminded you of your own kitty or your own animal that you love. If you've been listening to the podcast for a while, you probably heard me talk about this a while back, where he had some pretty serious cardiac issues and had to go on a diuretic and all this stuff for heart failure. And then we had a follow-up echocardiogram and x-ray, and guess what? He's totally fine. So whatever that was, it was an acute thing, and knock on wood, it does not ever come back, because that was scary and really expensive and not fun for us to take medication twice a day. He was not a fan. I was not a fan. But now he's doing absolutely wonderful, doing regular cat stuff and all of that. So thanks for all the well wishes about Oliver, and I hope his purring in the background wasn't too noticeable, and that you come back and listen next week when we are diving into a maternal newborn topic. We're going to be looking at molar and ectopic pregnancy. So I hope to see you back here for that. And I do have an announcement, something kind of fun that I created recently. It's called the Playlist Prescription. And if you're looking for help with a certain topic and you're not sure where to start, we have over 330 some episodes. And I know sometimes that's like, wow, that's a lot. I mean, it's a lot in a good way, but you also might want a little help targeting what to listen to when you need help with certain topics. So you can go to straightanursingstudent.com/prescription and choose the topic that you are working on right now that you want to learn more about right now. And I send you a playlist prescription, which is a list of the most impactful episodes to help you master that concept. So again, if you're curious about that, go to straightanursingstudent.com/prescription and get your free playlist prescription. Okay, I'll see you next week. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.